some systematic strategies to identify beta thalassemia traits so that if two beta thalassemia traits marry, you will find that in each pregnancy, there is a 25% risk that the baby can be affected with thalassemia major. So if both the partners are carriers, then prenatal diagnosis should be offered. There is this condition of thalassemia intermedia, which is actually genotypically very, very heterogeneous and clinically a challenge, as well as in the lab a challenge. And these disorders are usually like hemoglobin E beta thalassemia, or we sometimes get a spectrum of sickle cell disorder with a beta mutation, which may be a milder mutation. So these are now known as non-transfusion dependent thalassemias to differentiate it from thalassemia majors who require transfusions more frequently, and they cannot sustain their lives without the transfusions. So phenotypic severity is such that you can call it mild, moderate, or severe, depending on the number of transfusions that the patient is requiring. Now, when we say screening for thalassemia, the definition would be that this is a public health service wherein laboratory tests are systematically applied so that you identify individuals who appear normal but are at a significant risk for having a child with thalassemia or a significant hemoglobinopathy. Now, whom should we screen? And there is a huge kind of debate which happens sometimes between hematologists that whether we should screen school children, college students, premarital, preconceptual, like that. All of these could be screened. However, the most important thing to remember is that if there is an index case, then we must do cascade screening or an extended family screening. This is something which should be done and is usually done in most of the centers where screening programs are in place. Also, antenatal women, any pregnant woman who comes, at least should be screened once for hemoglobinopathies or the thalassemia trait status, because these women are always wanting a normal child, obviously. And this is the time where you don't have to do too much of counseling to the family, and straight away, the doctor writes investigations and the patient will get it done. So this is the perfect time to do the screening. And once a screening has been done for this antenatal woman, then in the subsequent pregnancies, there's no need to do another HPLC or a thalassemia screening kind of a protocol. Now, how to investigate? The clinical phenotype is extremely important because that is what is going to decide how much of molecular test or how much of lab tests which need to be done. So usually we like to do a hemoglobin HPLC or a high performance liquid chromatography, which is a dedicated system which is popular throughout India as the Biorad system, which is used. This is easy to use, and nowadays you have some more systems which are there in the market, but time tested, I would still say, is the hemoglobin HPLC by Biorad. Now, whenever you get an abnormal hemoglobin or an abnormal chain, at that time you must do a hemoglobin electrophoresis or an alternative technique. Now, in sickle cell disorders, alternative technique could just be a sickling test, which is a simple test in the lab which can be done.
Madam, there is one question. What is exactly done in cascade screening?
So cascade screening is known as the family screening. So family screening means if a child comes with thalassemia major, you need to screen the young people who are there in the family members. So who are these young people? It would be the Bua, Masi, then the siblings of the child. The parents are anyway just to be screened as to confirm what kind of abnormal hemoglobin is there. Usually, if it's a case of thalassemia major, then both the parents will be beta thalassemia traits. So you want to screen the chacha, mama, bua. So just the first degree relatives of the parents. And in the family, the sibling should also be screened. So you might want to see, supposingly now you screen the bua and she is normal, then probably her children may not need to be screened. But supposingly she turns out to be thalassemia trait, then her husband also needs to be screened. So when you say a cascade screening, you are talking about actually the family screening, extended family screening. And also when you're doing this, counseling is extremely important because they should understand why you are getting this test done. Now, sometimes you will find situations, and I think Dr. Mamta will be able to tell that, the family doesn't want to get screened, or they say that, the Chacha says that I don't want to get screened, because there is a kind of taboo which is there. But fortunately, this taboo is getting less, and people are concerned that, they should have a kind of normal child. So,
make a comment.
Yes, please, ma'am.
So basically, it's not maybe the chacha who will refuse, but this index case, my parents will say we don't want to reveal to our immediate relatives because they
Right.
will discriminate against us. So that becomes more challenging rather than the person we have advised who refusing. That also happens, as you rightly said. Sometimes they don't agree because they say we are fine. Why do you want us to be screened? So absolutely right.
So one of the screening modalities is the automated blood cell counter, where you get hypochromic microcytosis. So this is a typical kind of a, red cell indices that you would get, that the hemoglobin usually would be normal, or you might get mild anemia. But very typically you get the mean corpuscular volume, which is reduced. The mean corpuscular hemoglobin is also reduced. And you will get a RDW, which is near normal. Here it is mildly increased. And the red cell count will be increased. So very typically we say hypochromic microcytosis and with raised RBC count. So that is very typical for a beta thalassemia trait. I would also like to mention that alpha thalassemia trait, which is a much less problem in the country, will also give you similar red cell indices. But you might be able to differentiate or suggest that an individual is beta thalassemia trait or iron deficient anemia. But there are certain situations where you will find that typically, like in iron deficiency anemia, the hemoglobin goes down, the RDW is typically increased, the red cell count will be reduced. But situations such as during pregnancy, we don't want to take a chance. So in these situations, we would like to say that you must do the hemoglobin HPLC. The other important thing is that the hemoglobinopathies cannot be picked up by the red cell indices. So this red cell indices screening can only be useful if it is an uncomplicated beta thalassemia trait. And when I say uncomplicated, I would also include that, iron deficiency anemia is also not there. So there are a lot of, formulae kind of things which are also available, which can kind of help you. And the most important one that people use is known as the Menzer index. So we have kind of collaborated with the Aalborg University, where there was a scientist who has made an app. This app is known as a Susoka app. This is freely downloadable on your Android phone, not on the Apple iPhones. But this is kind of simple. Why? Because you just have to write these, enter these values, and you will find that it will give a option whether you should do a thalassemia screening or not. So this we have kind of validated in a large cohort, and majority of the cases. So here you'll find that if you use this app, majority of the cases will be picked up, but you will also pick up, because we've kept the sensitivity much higher, and so that the specificity really goes down. But at least we are trying to, not miss a case. Beta thalassemia trait. So this is just one of the modalities which has come up in the last couple of years. So when you do the screening programs, the mean corpuscular volume of less than 80 and mean corpuscular hemoglobin of less than 27 picograms is a very useful kind of parameter which is there. So peripheral smear examination, beta thalassemia traits, you have uniformly, most of the RBCs are hypochromic microcytosis, and you will find that some target cells may be there. And this is a RBC which would be actually known as a mesocyte, which means that you have this pallor which is there in, 2 bits over here. This is just an unusual cell which is there. And this is a smear of beta thalassemia major. A lot of anisopoikilocytosis is there, and you get nucleated RBCs in the peripheral blood. Thalassemia intermedia, the RDW is disproportionately increased compared to the hemoglobin. So you find a lot of anisopoikilocytosis, very small RBCs, target cells, etc. Now, the hemoglobin HPLC or the high pressure liquid chromatography, this is an automated instrument for the hemoglobin HPLC, and this is how a graph of a normal person would look like. You will get very less amount of fetal hemoglobin. The A2 concentration here is 3.2%, and the adult hemoglobin is kind of normal. So this is a thalassemia major, where you find that the majority of the abnormal hemoglobin which is there is actually the fetal hemoglobin. So usually we always say that we should not interpret the graphs, we should interpret the case as a whole. You should look at the clinical feature, because like supposingly now, just for an example, I get a newborn sample and we get predominantly fetal hemoglobin. So for the newborn, it is normal. But supposingly I get a child who is like 1.5 years old, requires, has severe anemia with hepatosplenomegaly, failure to thrive, and we get a graph like this, then we'll call it a thalassemia major. A similar graph in an adult who has not required any transfusion, but you see a single, peak like this, you'll call it a thalassemia intermedia, which is like a mild kind of a phenotype. So we always say that don't interpret the graphs, interpret the case as a whole. So you must have some clinical idea, and also the red cell indices and the hemoglobin and those kind of parameters whenever you are interpreting your hemoglobin HPLC. And this is a beta thalassemia trait at the end, where you can see that the hemoglobin A2 concentration is increased. So once you have learned the knickknacks of looking at the HPLCs, it's a fairly like a simple kind of a test to be done. Now, we have to remember that there are certain situations where you can get a false high hemoglobin A2, and this is the reason why sometimes the clinical picture is so very important. So if you get a hemoglobin which is say 4 grams, a reticulocyte count which is say 25%, and I get something which is just looking like a beta thalassemia trait, then I have to think about unstable hemoglobins. So the clinical picture is extremely important. Or if you get red cell indices which are not matching, looks like a megaloblastic anemia according to, or a macrocytic anemia according to the red cell indices, and the A2 is increased, it could be just because of the falsely high HbA2. Similarly, we can also get falsely low hemoglobin A2, such as in silent beta thalassemias, or else in a severe iron deficiency anemia, and some of these other conditions which are there. We have found that, analysis which was done in our thalassemia major children, that majority of our children in Punjab, they are Khatri Aroras. So what do I mean by this? That there are certain communities within India where the frequency of thalassemia is higher compared to others. Predominantly because there is a kind of either consanguinity which is being practiced, or a semi-consanguinity where we say that Indian marriages are happening in the same caste. So I always tell the youngsters, have love marriage and have, different, communities intermixing, which is actually good, so that for the genetics of the disease, there will be dilution of the thalassemia genes, but that is just on a lighter side of the story. Okay. So there are certain diagnostic caveats. I told you red cell indices may be normal in a beta thalassemia trait. A child may already have received some transfusion, and at that time, when you do the HPLC, you'll find that the HPLC looks completely normal. So if we get a child like this, we do the HPLC of the child, but more important than that is to do the HPLC of the parents. And if you find that both the parents are beta thalassemia traits and this child has received a transfusion, then it would be like a presumptive thalassemia major, and a molecular testing may be required. And molecular testing is of course required whenever we have to do a prenatal testing. If we look at the mutations, this is just a enlistment of some of the mutations which can be there. These are just different names of the mutations which are there, which happens as the pathogenesis of the different types of mutations, and we'll not go into the details of it today. What is important for us to remember is that there are certain common Indian mutations, such as the IVS15 G2C. This is seen all over India. You will have some mutations like the 619 base pair deletion, which is more common in the Sindhis and Punjabis and certain communities, which is also similar to the IVS11 mutation. And there are certain mutations like the frameshift 4142. This mutation is common all over India. So just to keep in mind that mutations like from frameshift 8-9 or frameshift 4142 and IVS15, it is seen all over India. And these are the severe kind of mutations which are there. But also to remember that there are more than 300 types of different beta mutations which are known worldwide, and the list keeps on increasing. So we always say that anything can go wrong. This is the beta globin gene is the perfect example of that, because almost every nucleotide has mutations and changes which are there. Some give rise to problems, some don't give rise to any problem. Very typically, the type of DNA analysis which is done all throughout the country, which is popular, is known as the ARMS PCR, or the Amplification Refractory Mutation System. Whenever we do an analysis like this, we must have a control band. And in this case, you can see that the 861 base pair is the control band which is there. And the primers which are added in the tube will give rise to a specific mutation which is there depending on the size of the mutation. So that you can see that this is the band of IVS15, the common one, which measures about 285 base pairs, versus the 619 base pair deletion, where the mutation gives rise to an additional band over here, which is 242 base pairs. So we must have a molecular weight marker, which will help us to identify the size of the mutation. So this is a case history of a 30 years Punjabi lady. She was screened in the antenatal clinic in Singapore for beta thalassemia trait, and she tested completely normal. And because she was normal, her husband was not screened, which is the usual thing to be done. Her son, when he was about 3 years old, he seemed to have significant anemia. And when we looked at the red cell indices, after the evaluation, that this child looked like a severe thalassemia intermedia, we found that the patient has a hemoglobin of 6.6. The mean corpuscular volume and the mean corpuscular hemoglobins were reduced, and the fetal hemoglobin was increased. The hemoglobin A2 was also increased. Now, the problem was that the mother who was there, the mother's hemoglobin was more or less fine, but the MCV was also borderline normal, 79.7, and because of that, and looking at red cell indices, her A2 was found to be 2.9%. Now, 2.9% is a A2 which is completely normal, and therefore she was not screened. When the mutational analysis was done, she turned out to be a CAP+1 mutation. So I told you that some of the mutations can be very mild. So this is known as a silent kind of mutation which is there. In addition, she also had an alpha gene deletion, and because of that, her A2 was falsely low. So we have to keep in mind that whatever screening modality that we take up, there might be some cases which we are going to miss,